Welcome everybody to our webinar. We're just giving people a few more moments to join and we'll be up and running. In the meanwhile, you can be thinking about any particular questions that you have, burning questions that are on your mind, and put them in the chat box if you have some. And you can be doing that from now. We're also recording this and it will be made available to you. Okay, there are more people joining, but it's 2 o'clock here in the UK, 10 o'clock in the USA, and wherever you are, greetings. We're delighted that you're here to join us for this webinar this afternoon. I'm Barbara Stillwell. I'm the Executive Director of the Nursing Now Global Campaign. And as you know, we're having a season of advocacy at the moment, which will run until April. And we want to do this because in the campaign, we recognize that we're now at really a critical moment for nursing globally. This is a moment when we're all going to start recovering, we hope, from the pandemic. And we're going to be looking at our future health workforce. And we know already from State of the World's Nursing that we have a shortage of nurses and midwives around the world. So we want to pay particular attention to how we invest strategically, or how we get our governments to invest strategically in nursing to attract people into the profession, to keep them in the profession, and to make sure that nurses everywhere have decent work. So that's the focus of our webinar today, is how do we make those strategic asks? And goodness knows, I live in a country where there's actually a lot of fiscal space for investing in health systems and investing in nursing, but it's often not easy to make the ask strategic. So what am I going to ask for that politicians are really going to want to invest in? How am I going to hold them accountable? How am I going to make those arguments for that investment? So that's what we want to focus on today. And we have a very distinguished and stellar lineup of people for you this afternoon. We're absolutely thrilled. We're going to first of all hear from Rachel Dewsome. And I've known Rachel for several years. In fact, probably 10 years, Rachel, if I think about it. And Rachel's a global technical director for one of USAID's, or actually the biggest program, the biggest investment they make on human resources for health around the world. And, you know, there's hardly anybody in the world more savvy about HRH investments than Rachel. So Rachel, we're thrilled to have you. And we know you're going to do a great overview. Then we're going to hear from Ben Sims, who is the CEO of the Tropical Health and Education Trust. And Ben is going to talk about partnerships. And Ben and Thet have done some amazing work on partnerships and how partnerships enrich all partners. And we want to hear about that, how nurses can really maximize the benefits of partnerships and seek good partnerships. And that's also been a focus of our Nightingale Challenge and will go on being a focus of the Nursing Now Challenge, of which Thet is a part. So that's a great look forward as well to what we will be doing. Then we're thrilled that Judy Kanyola has joined us from Rwanda. Judy has been a friend of Nursing Now from the get-go. She's been a consultant. She's really been a tour of strength for us. And Judy, we're delighted to join us. Judy's not too long ago become chair of the Center for Nursing and Midwifery at the University of Rwanda in Kigali. So Judy's going to talk to us about getting strategic investments in nurse education, which if we're going to have more nurses is going to be completely critical. And then we'll hear from David Bryden, who's the director of the Frontline Health Workers Coalition. And David's going to talk about advocating to donors. So what a lineup, what a panel. Please get those questions coming. I can see we've already got people greeting us from all over the world. You're so welcome to this webinar. And I'm now going to ask Rachel, can you please get us going? Thank you, Rachel. Thank you for being here.
Thank you, Barbara. Greetings to all. Thanks to Nursing Now for the opportunity to share with you today. I'm Rachel Dessum, as announced. I'm Technical Director of the HRH 2030 program, which is led by Chemonics International, and I'm also a steering committee member of the Frontline Health Worker Coalition. You'll hear from David on more about the coalition later today. I'm honored to be in the outstanding company of so many nurse leaders. My family's health and well-being have been cultivated by nurses throughout our lives. So as momentum for the Year of the Nurse and the Midwife extends into the Year of the Health and Care Worker, in the face of a global pandemic, health workers are celebrated as heroes, responding to threats and delivering essential health services. So I want to start my presentation by first saying thank you. Merci, gracias, asante, shukran, obrigada, terima kasih. But thanks and applause is not enough. We need real and concrete investments and actions in health workers. You deserve these actions and investments for your dignity, your safety, and your success. Global health investments in the health workforce are key for harnessing the full potential of health systems, providing global health security, and delivering essential health services and health for all. In addition, they drive improvements for health and development goals, including gender equity and decent work. Nurses are central to the global health agenda. Why? There's an estimated 28 million of you. 9 out of 10 of you are female, are women. That's a strong and amazing force. This is the largest occupational group in health, and you are right there on the front lines every day. But nurses also face important challenges. There's an estimated shortage of over 5 million nurses in low and middle income countries. And while the production of nurses through education has increased in recent years, the quality and the preparation that nursing graduates are getting is not always sufficient to help them really do the best at their jobs. And as we look at the most fragile and hard to reach settings, the decent jobs for nurses are far and few between. And the distribution of nurses across a country or around the world is quite inequitable. And nurses are working hard, but they're not staying in the profession as long as one might hope they'd be able to, but a lot of this may be due to burnout and challenges they face at the job. And ultimately, in terms of making decisions, we need more nurses making the big decisions and being the leaders. So how can we increase and target global health investments to the nursing workforce? I'm going to share some examples at various stages of workforce development, some investments that might be shorter term, others that are longer term, some that may be more for private versus public sector settings, both past and present. And I'll describe how global health donors and initiatives have been supporting nurses. And to be clear, I'm reflecting on my experience over the course of my career. I've been both on the donor side and the implementing side, and I'm not endorsing any particular initiative specifically. So let's start with a nurse-centered life cycle approach. I'm hoping that this presentation will really give you some ideas and spur your imagination for what kinds of asks you might want to make. Here's what has been known and may be possible, but we really want to hear from nurses when making these investments. We want to know what you are needing. This graphic here was developed by the USAID-funded HRH 2030 program, and it adapts from a health labor market framework. So we can think of these orange, green, and blue sections building, managing, and optimizing the nursing workforce. First starting with the orange section, within the education sector, we need to be recruiting promising nursing students, training them appropriately, and graduating them. Then within the health labor market, the green and blue sections, efforts are needed to make sure that nursing graduates are connected to safe and decent jobs that are well paid, that take them where they're the most needed across the country, and that they stay there and they thrive. This requires investments in workforce planning, policymaking, financing, monitoring, and support. And then during their careers, thinking about how you'd optimize the workforce, we really aspire for nurses to learn, adapt, and respond, and grow and advance as leaders and agents of change in their communities, ultimately improving health outcomes. And this requires support and investments in the health system, facilities, infrastructure, and in the professional workspace. So digging into building the future nursing workforce and leaders, we need to train more nurses from diverse backgrounds, representations, and origins. And oftentimes that might be in how you select your future nursing students and really ultimately support their success to graduation. More underserved populations have a lot of financial and social barriers to successful enrollment and completion of nursing studies. We have known a number of bilaterals and private sector companies like Johnson & Johnson, GE, Philips, and Hewlett-Packard to make investments in scholarships for STEM, science, technology, engineering, math, and medicine. And I think many of them are very keen to investing in nursing as they see nurse leadership as really valuable. In addition, there are things like training materials and equipment to improve the quality of nursing education. Bilaterals like JICA and COICA, the Korean and Japanese international cooperation agencies, will often provide these sorts of materials and sometimes even build schools. And in addition, USAID through PEPFAR has developed the Nursing Education Partnership Initiative. It has closed, but it supported investments like infrastructure, curricula, management and leadership, technical exchanges and partnerships with nursing schools across Africa. And there's now a sort of sister initiative in nursing education that's led by PEPFAR, but it's much more focused on specifically fragile settings and countries. Longer-term investments in nursing education quality may be curriculum development. That can take time, and as probably many of you, if you're nursing educators, you're aware there are a lot of bureaucratic hurdles to that those can be really key for having the workforce prepared for the sorts of issues and health challenges that they face. And ultimately, it's also very important to diversify and invest in the nursing faculty pipeline. We see in many countries you require a doctoral degree to teach at the tertiary level, and that's really quite an obstacle. So think about if there are any policy levers, or if that would really help to open up a more diverse and qualified nursing faculty, especially when nurses may be retiring. Couldn't they have a wonderful and amazing second sort of career teaching? When we then think about managing, technical assistance is often provided to look at job packages and incentives for the nurses' unique preferences on the job, to understand what's desirable to them in terms of deployment, retention, and career paths. Oftentimes we see with the civil service that the salaries themselves are not particularly changeable because of the much broader policy context. But we know that the World Bank, for example, supports ministries of health to provide that fiscal space. And they may also provide technical assistance and research and evaluations on where health worker salaries fit into some of the broader budgeting questions. And I'll leave it to some of our advocacy folks to provide more nuance to that comment. There's macro and country level workforce planning to develop strategic planning for the workforce. WHO, the World Health Organization, as well as DFAT, which is part of Australian aid, and other bilaterals may offer support in these areas. And linking workforce strategic planning to broader health plans can be really key. So as you're thinking about the sorts of asks you make, I encourage you to look at some of the guidance documents that the Ministry of Health has set forth, understand what the goals are, and really connect the dots to where nurses are already contributing to this and how they could do even more. And given the gender issues and gender equity issues within nursing, and that it's a strong female-dominated workforce, it's really important to also look at how gender discrimination, vertical and occupational segregation, and sexual harassment can be addressed at the policy level in the countries where you work. Ultimately, then, when we think also about optimizing the nursing workforce in the day-to-day across the health system and over time, what are the kinds of investments that can really help nurses thrive? In the very short term and in the emergency settings, we see a lot of countries delivering hazard pay or top-ups to nurses and to health workers writ large. This can be challenging, getting the money in a nurse's pocket due to different bureaucracies and sometimes very slow financial systems, which may or may not be very digitized. If nurses can organize and kind of manage upwards, the hope is that there might be some more connections made and much more could be done to respond to those immediate term needs. But ultimately, in the short, medium, and into the longer term, improvements to nurses' working conditions are important to retaining them and to really their own productivity and performance. I have visited too many facilities where nurses or midwives have been the ones to go get the water so that they do have clean and sanitary working conditions. Obviously, the challenges of PPE, especially right now, and when a lot of protective equipment are not built for female physiques, this can be a challenge and a hazard to nurses. When we think of investments in terms of quality and continuing professional development, many bilateral programs, USAID-funded programs that are in specific countries or focused on particular disease areas like maternal and child health, family planning, malaria, tuberculosis, or HIV, will do very programmatically specific in-service training, and often that's accompanied with coaching and mentoring, and thinking about how you can leverage some of those opportunities for broader professional development is something that I would encourage you to take a look at. There are also some tools to help manage workload pressures, to enumerate the number of health workers at a facility and think about who can be doing what and when, and that can be useful information to advocate for furthering some of that task sharing or reallocation of tasks within various settings. And then I think another important point to raise is that when we're thinking of investors, this may feel like you're trying to go up to an ivory tower, some sort of unknown entity and provide these asks. But I would also really encourage you to look at what is around you. What are the local councils? What are the local processes? What does your professional association or council have locally, and how can you build those out to have a unified, voices heard, clarity on what the asks are, and look to some of those more immediate, local councils and government, as well as local communities. We have seen, for example, in terms of improving working conditions, local health committees can do a lot if it's engaging the community to provide water, provide the nursing quarters so that they feel safe, addressing some of the issues in terms of safety on the job, that there is a lot of the small p private sector, as I like to say. So think also broadly and try to look at what is potentially right in front of you. I'm going to close with just this to reiterate. Global health investors really want to hear from you. They want to know what is going on. They, I think that the more that you can organize and communicate messages on what is needed to build, manage, and optimize the nursing workforce in your setting, the more you can discuss what kinds of solutions seem the most feasible and attainable, and really responding to what those needs are will get you very far. And I encourage you to think about what are some of the short-term, most immediate kinds of priorities versus some of those longer-term priorities, and how those things may be able to build upon each other. But really, I just want to encourage you, remind you that by virtue of being on this call, you are nursing leaders. Your issues are also women's issues, and that there's a lot of solidarity, that the global health community should be valuing nurses, compensating nurses, counting nurses in terms of knowing who they are, where they are, and really digging into the data that can give the evidence, the compelling evidence to get those asks responded to. And that accountability mechanisms, as you identify them through independent global and regional mechanism and national mechanisms, really can get you far, but that, you know, we need more nurses as leaders to provide health systems, support global health security, and deliver health for all. So thank you.
Rachel, thank you so much. That was just wonderful. It was absolutely perfect. I love your last slide. It's such an important slide. In fact, I think we might adopt it in nursing now. Nurses' issues are women's issues, indeed. It's very hard to get around that, isn't it, with 90% of the workforce being women. And I think there was the way of organizing it, I loved, into getting people in and managing them and optimizing the workforce. I think that's a great way of looking at it. One of the things that I particularly noticed was the advice to look at the national workforce plan and see where nursing is in that. And I think nurses are often very slow to do that, and that's great advice. Where are the nurses in your national workforce plan? Thank you so much, Rachel. And I'm now going to turn to Ben. Ben, welcome. We're so pleased to have you join us, and we're very much looking forward to what you have to say today. Thank you, Ben. Over to you.
Thank you so much, Barbara, and thank you to Nursing Now for inviting me to join you today. Congratulations to Nursing Now. I've been just transfixed by what you've been achieving as a community over the last several years. And one of the most important messages for me is that FET wants to sit alongside you and help secure the legacy of the campaign, because there is still so much to be achieved to raise the status and the value of nursing in the minds of government and decision makers and donors. So we absolutely commit to working with you to secure that legacy. And I think every nurse has a role to play in this. And what I would like is that the other side of my presentation, everyone on this call feels extremely empowered, that they really feel like their experience is experience which can play directly into influencing decision makers, because you're a wonderful group of people. And I say that particularly at this time, recognizing the stress and the pressure you have been under and are under during COVID. I congratulate you and thank you for the role that you're playing. I wanted to start just to sort of explain where on earth I'm coming from. So FET is a small British charity, but as Barbara said, we're very well known for our health partnership approach. So we were created about 30 years ago. We manage about £10 million of funding each year. We work very closely, mainly with UK institutions like the Foreign Commonwealth and Development Office, like the Department of Health and Social Care in England. But we also work with partners like Johnson & Johnson, who Rachel praised earlier. We're very much influenced by Nigel Crisp, aren't we all? I can say that in this company. So Nigel's emphasis on themes like co-development, on his wonderful book, do you remember, Turning the World Upside Down, which is about respecting expertise wherever it is, not assuming that expertise resides in the global north solely. And so we're very inspired by Nigel, as I know the Nursing Now campaign is. And this health partnership model brings that vision of co-development, of bi-directional learning alive by linking up institutions, health institutions in the UK with institutions overseas. And there are perhaps over 300 such links that we're aware of, all across the National Health Service in the UK. And one of the most wonderful things, I suppose, is that when a year ago the pandemic hit us, I think a lot of us sort of felt, oh my word, we're gonna go in on ourselves. We're gonna turn very insular. How on earth can we expect anyone to have a conversation with anyone from another country when their own lives, their own working lives are under such pressure? And I was completely wrong to expect that. And one of the most wonderful things about this period has been on a human level, on an individual clinician level, on the level of nurses and of doctors, that solidarity has flourished. It has not flourished at a governmental level. I'm not suggesting that for a moment, but on a human level, the ties that bring people together because of their common shared experience as nurses, those ties have flourished, and it's been really important. And so, you know, we have a conference on Friday, which Judy is also speaking at, which will focus on solidarity at a time of COVID. And you're very welcome to join us. So I'm just going to linger a little bit on the grant making programs. And I suppose there are two thoughts I have in mind. One is, you know, come, get your hands on this funding, join in with those who are applying for this funding. The first one that's worth mentioning is the UK Partnerships for Health Systems. Now, this is a UK fund which Nigel Crisp hugely influenced. So 5 million of this is dedicated to nursing. And the fund is very much supporting health partnerships, but we sat down with various governments and asked what it would be most useful for us to do. And so the kind of work that we'll be doing in this is reviewing nurse curriculum in Somalia and Tanzania, strengthening pre-service, in-service training in Somaliland, developing capacity of nursing services in Sierra Leone, and so the list goes on. There's various pieces of analysis that you can find on our website about what this grant making will achieve. And I emphasize that because, of course, to do advocacy, isn't it wonderful if you can do advocacy with funding, if you can do advocacy on the back of projects that you're able to pilot to innovate, on the back of research that you're able to do. And this kind of funding, which is focused very much on quality improvement initiatives, is very much the kind of funding that I think can flow into that advocacy. And in every country where we've sought to do this work, we've made a touch base with Nursing Now groups. So a piece of reassurance there. I want to talk about what makes a good application, just because I think it's terribly important to get that funding for advocacy. So there are two things I really want to emphasize, which are really qualities of the health partnership approach, which matter greatly to us. One is that wider system change. So change, and you know, in individuals is great. The improved competence of individuals is an exciting thing to behold. But when those individuals then go on to influence the system and bring about systemic change, whether that be at an institutional level or whether that be wider, when those individuals begin to be listened to by ministries of health, by policymakers, by decision makers, that really is very exciting. And we're determined to provide routes for nurses to have that kind of influence within this program. And the second thing, again, which is available on our website, is this underlying principles of partnership. And I've laid out a few of them here. And the thing is, you look at these slogans, if you go to the website and click on each of these banner headlines, you can then find case examples of how people are being strategic, of how people are being respectful, the kind of approach that makes for successful equal partnerships, which are really the themes that I spoke about at the beginning that matter so much to Nigel Crisp and to the vision of co-development. So I feel that advocacy is a very exciting space. Rachel mentioned this. The shortage of health workers is devastating. The pressure on health workers is devastating. But the potential to influence is what I'm excited about, especially at this time of pandemic. We've seen, haven't we, pandemics in the world before. What is going to make this one different? That's what we should be strategizing to think about. We've seen, what, 30 more million people die of HIV and AIDS. And yet we are still taken by surprise by this latest pandemic. So there's nothing to be taken for granted. We need to work with urgency and passion to ensure that this time the world learns the lessons in a way that previously it hasn't. But it's a very exciting space, which has a lot of respect for people's expertise, for the authority they bring. And of course, the world is smaller than it used to be. One of the favorite pieces of advocacy that FET emphasizes is looking at the migration of health workers. The fact that the NHS in the UK, where I am, has been dependent on overseas recruitment since 1948, in other words, the year it was created. We are utterly indebted to health workers who travel great distances to join us and work in the NHS. So those themes of migration are terribly important. And with it, themes of racism, themes of diaspora, themes that are really important in terms of advancing our advocacy agenda and our respect for the role nurses play. So I want to conclude by just saying, looking at the power of the individual. And Barbara, this quote comes from you, because when you briefed me, you remind me of this lovely saying by the Dalai Lama. So I thought I would include it in tribute to you, Barbara, which I love. But I would also like to pay tribute to the Burdett Trust. And I am so enjoying working with the Burdett Trust, with Lisa Bayliss-Pratt, professor at Coventry University, to secure the legacy of Nursing Now through the award of Nursing Now Challenge Fellowships. This is another really important part of what FET wants to contribute going forward. And we are determined to make advocates out of every single one of those nurses who takes part, and providing those routes through to influencing governments, to making sure that your views, your expertise is respected and influential. Thank you very much for having me. It's really wonderful to participate in this. There are my contact details if anyone wants to contact me, but thank you very much.
And thank you so much. That was a wonderful overview of partnerships and the power of partnerships. And I urge everybody to look at the FET website under those banners. There's lots of really good advice and ideas about how to construct a partnership application. And, you know, it's so important if we're looking for funding. Funding, unfortunately, never comes by magic. How I wish it did, but so far no luck. So, you know, we've got to get good. We've got to get good at putting in those applications and who we work with and how we look at mutual benefits across partnerships. And don't forget FET's conference on Friday. So go to the FET website. There's a lot there to see. Thank you so much, Ben. We're already getting some feedback and thanks from those listening, for both you and Rachel. And now I'm going to turn to Judy. Judy, welcome again. For those of you who've joined, and we've been joined just constantly really since we went live. So for those of you who joined not too long ago, Judy is based in Kigali in Rwanda and is the chair of the Center for Nursing and Midwifery at the University of Rwanda, based in Kigali, and is or was on her terrace. I think she may be inside, but Judy, welcome. You're so welcome. We're all very envious of your wonderful background, and we look forward to hearing what you have to say. You're on mute, Judy. the most used sentence in the British language these days.
Of course, sorry.
That's it.
A testament to our times. You're on mute, you're on mute. Good afternoon, everybody. Good morning. Thank you very much, Nursing Now, for having me here this afternoon. And I will just quickly go into it, looking at nursing and midwifery, and specifically education, because this is sort of where I sit right now at this point in my life. And talking about how to engage perhaps donors, looking a little bit about rural retention, and just giving us food for thought from my perspective and experience. So the first thing I want to ask everybody, when nurses and midwives in Africa are educated, what will we see? And this is sort of the case, I say, this is building the case to a donor if we are looking for funding or for partnerships, like Ben has talked previously very well. And I think broadly two things. We are going to see a continent able to take care of its people. And here I'm specifically speaking about Africa, where I live and work. And these are just very, just a few of the things that nurses work in to support, promote, prevent, help malaria, TB and HIV, immunization programs. I just yesterday got my COVID vaccine, and it was actually administered by a nurse, and all of them are being administered by nurses. I remember last year when COVID came in March last year, a year ago, I asked somebody, so this vaccine that you're all looking for, who is going to administer it? And everybody looked at me blankly. And then they're like, well, all the researchers and everybody are racing, and it's great that we're able to do this in such a short time. Kudos to all the time, effort, money that went into developing the vaccines. And then now the vaccine is out there, and who is going to administer this vaccine into your arm intramuscularly? It's a nurse. Maternal and neonatal health, non-communicable diseases, mental health, aging, even in Africa, is now an issue, and its associated morbidities, and all other emerging disease threats and outbreaks. So now we are looking at COVID. In Africa, we still battle a lot with Ebola. It keeps, going up, coming up, going down, coming up. And then secondly, we'll advance 3 critical global initiatives. And this is the Global Health Security Agenda, Universal Health Coverage, and of course, we all know the UN and SDGs. So when we're looking at building the case to donors to give us money, give us shillings, give us pula, give us francs, give us cedis, what are we going to see? This is what we are going to see. What then, because of that, do we need in order for us to have this beautiful picture that I've sort of tried to give an outline of? What do we need? So first of all, I always say, before we go out, first, make sure what is inside is okay. You can't go to clean your neighbor's house when your own house is dirty. So internally, from our African governments, and I hope some of you are here on this call listening, I put there the Abuja Declaration because I only have 10 minutes. And I want to say that if we can at least do the things that are already set out before we go to make another global goal, another declaration, another what, the ones which are already there, can we at least make sure we're doing that? So if we have 15% that is going towards health, that's a good start before you go out to a donor with your heart in hand. Our ministry, and of course there are others, our ministries of health, can we please create the position of a chief nursing and midwifery officer in the many countries out of 54 in Africa that do not have? My own Rwanda here where I work, we do not have a chief nursing and midwifery officers. Some countries had them and then they pulled them out, So very many countries in Africa still don't have this position. And with that, not just creating the position, because there are countries which do have this position, but this chief nurse is not included in the Ministry of Health leadership. She's somehow relegated there, sort of like a tokenism, if I can call it that. Then from the Quad in Africa, from the policy, when we have this chief nurse and midwife, we then need to know what is she supposed to do? What are the policies, for example, she needs to make sure we have in place? From the schools of nursing and midwifery, such as the one I sit in, academia, what do we need to see? From the councils and the boards, and from the welfare. So first of all, we need to make sure our house is clean. And then when we go to the donors, I first of all want to talk to donors here briefly. Please understand that the massive investment that donors have made in the last 20 years or so has resulted in positive change. So the work that donors do is not in vain. And often I think many of the reports or the information that comes out sort of paints that, oh, aid is a trap, it leads to debt. And while there are some, arguments to be made for that, I want to say that at least in the area of nursing and midwifery education in Africa, this investment has resulted in a positive change. Then you need to understand the landscape of nursing and midwifery in Africa. Again, because I only have 10 minutes, I just broadly put this as around curricular reforms, and colleague who spoke first mentioned this, profession regulation. We need to strengthen the regulation of our profession. We need to make sure we have transformative teaching strategies, and this does not mean going to slides that you made in 1990 and keep on teaching them in 2021. Can you please refresh your slides and teach in a manner that will show that we are in the 21st century? Collaborations and partnerships. We don't work in silos, so we must make sure that this goes hand in hand. We need to build capacity. So these are the areas that if you're a donor, you need to perhaps can put money in, infrastructure and resources. As a donor, focus on nursing and midwifery leadership development. I always say this one, it's like hitting two birds with one stone, or three birds with one stone. What are those birds? When you have good nursing and midwifery leadership, you then get effective service delivery, you have successful health system redesign, because that's an impact on our very weak health systems here in Africa, and you counter the impact of the HRH shortage in Africa and its effects, because the nursing and midwifery leadership has a ripple effect on these three. Then focus on people and country-centered programs, of which, of course, we all agree nurses and midwives lie squarely there. Because when you do that, it stimulates the local economy, reduces aid dependency, and I'm urging everybody here, please, if you are a donor in a position to do so, employ nurses and midwives, okay? How can we encourage then that I've talked to donors? I now come back to us. How can we then encourage the donors that we want to give us a few shillings to invest in the education of nurses and midwives? So really running through this very, very quickly, build the case. I've already said this previously, but I just want to add that females drive economies in Africa. When you educate a woman, you eradicate poverty there and then. My mother walked miles and miles for me to go to school. And because she has educated me, I have made sure my nieces, my nephews, my husband's sisters and brothers have got minimum education just through the fact that I went to nursing school, and now I am in a position to get money and make all those people come out of that poverty that often is a trap in Africa. Demonstrate, for heaven's sake, internal capacity and capability. If you want Ben Sims from FET to partner with you, you cannot bring him to a broken car. Fix the car, fix your house, fix certain things so that we ensure basic infrastructure is in place. As minimal as it is, at least let us have something. Show that you collaborate and work with others. I think we all agree that we are better off working together than alone. Consistently show results. Peer to peer. I often say sometimes I, as Judy, may not be able to meet somebody, but I can talk to Barbara, and through Barbara, I'll meet somebody. And that's sort of what I mean. Personalize, go to the heart. I have a donor who I'm working with, and his mother is a midwife. So I quickly pitched midwifery, and he was so happy. Because when you go to the heart, all of us are human beings. There is something that touches us. These are such important things to do. Advertise, host an event, curate your content. If you go to the website, for example, at some of the universities we have in Africa, it is so old. It is so lackluster. Can we curate our content? Have a call to action. What exactly is it that you want to achieve? Then have a directed goal. So for example, me here, my current 3 to 5 year plan is to develop curricula and put in certain leadership programs within the university. So if a donor, I'm speaking to a donor, I already have that goal in mind. It's important for us also to educate donors on mismatch when it occurs. Oftentimes, for example, I'll give an example. PEPFAR came in the 90s with HIV. And because of what PEPFAR was doing in Africa, they were requiring certain HRH. For example, they'd work in 10 hospitals, to give an example. And in those 10 hospitals, they then required 14 extra nurses and midwives to do this PEPFAR work. And these nurses and midwives could not do global fund work. So that mismatch has a very bad effect on the locals on the ground. So we need to also make sure when we are partnering and working with donors that we apprise them of some of these issues. Know your organizations. In Africa, we have WHO, Afro, we have the AU, we have EXA, we have ECOWAS, NEPAD, SADC. Then we also have like-minded organizations like AfriHealth, AfriPen, AfroPHC, the Advanced Practice Nursing Network in Africa, Hexacon, WACAN. All of these are people that we need to know and work with to make sure that we achieve our goals. I'll briefly touch on rural retention. And here again, I'm still going back to my rallying call on nursing leadership. If we don't have nurses in positions of leadership, don't have a chief nurse, for example, she will not, this issue of rural retention policies and things that support that will not come to fruition. So first of all, before anything, we need the nursing leadership. Then we need financial incentives. Countries like Ghana, for example, South Africa, Kenya, Botswana have certain incentives for nurses who practice in the rural area, maybe 30% salary, or you get a certain allowance based on certain parameters that the country uses. This is very important, it's good. However, studies have shown that this is not enough in and of itself, and we have non-financial incentives. And here we're looking at things like clear career pathway and promotion, things like, even a cup of tea when you're on duty and things like that. We need national policies on rural retention, and we need multi-sectoral collaboration. I worked in DRC Congo to develop a program for rural retention because many of our African populations live in the rural area. And surprisingly, the biggest issue they had was water. So, if we can work with the Ministry of Water, with the Ministry of Housing to just have roads, accommodation, water, all these work towards ensuring that we have our workforce retained in the rural areas where, again, I've just showing, populations are 70% of Tanzania lives in the rural areas. In Burundi, it's 87%. South Sudan, 80%. Rwanda here, 83%. Niger, 83%. So you can see the huge thing that's needed for nurses and midwives or our HRH to work and be retained in the rural areas. And we need to give them training skills to provide primary care. 60% of rural facilities are headed by a nurse and midwife. And so right there is just so much work that we need to invest in to just build that. We need leadership and management training. Of course, like I keep saying, align with other community health trainings which are already there. And for heaven's sake, like I say, let us use technology. These are just some of the key competencies within these leadership training programs. And, they're straightforward. We need leadership and management skills, planning, community guided QI, working with CHWs, resource mobilization, coaching, evidence-based clinical practice. All of these are just some of the competencies that we need for a rural nursing leadership training, which are important. We do have a number of trainings in most of the countries here in Africa, I'm happy to say. And this, again, is another way for us to make sure that, whatever money is coming is also being directed in the right place. Colleagues, I thank you.
Judy, thank you so much. You've covered such a lot, and Somebody wrote in the chat box, you're so inspirational, and all I can say is you are really inspirational, Judy. Thank you so very much for sharing those messages. I particularly just want to pick up on something you recommended about having a CNO, saying, you know, we need a CNO. Every country should have a CNO, a Chief Nursing Officer. And this year at the World Health Assembly, there's going to be a resolution put to the Assembly on nursing, on the strategic directions in nursing. So to all of the over 100 people on this webinar, you need to make sure your CNO, A, you have one, and B, your CNO is in the delegation. So important to have one, as Judy has said, particularly this year. Thank you, Judy, so much. I know we're going to pick up on some of those things in the questions. So please put your questions in the Q&A or in the chat box. I'll be looking for them. But now I'm delighted to introduce David Bryden to you. David is the director of the Frontline Health Workers Coalition and is going to talk to us about advocacy with donors. Over to you, David.
Great to have a chance to talk with everyone today. Thank you so much, Barbara. It's really quite an honor to be on this panel and to be able to talk with all of you today about advocacy and what we need to do to make change. So I'm David Bryden. I'm the director of the Frontline Health Worker Coalition. We're an organization of 38 groups based primarily in the US with one single-minded goal, which is to really fight for the needs and the rights of health workers in lower and middle income countries. And so it's a real pleasure to be with everyone. So I'm going to just talk about a few advocacy principles, some of the things that we keep in mind as we're advocating for whether it's policy changes, whether it's funding. And then I'm going to come up with a few examples that I want everyone to think about in terms of potential funding sources and ways to, as Judy was saying, meet the next person who could be your ally. So let's just start in with a couple of slides. Let's see, I'm going to see if I can share my screen here. Yes, we can do that. Okay. So there's a couple of resources that I want to start at and make you aware of, but I want to start out with this. If you look at advocacy, we often think of, oh, what's my strategy? And we think very much in terms of the arguments that we're making, the rational points that we're making, point by point. And we hope that adds up to a compelling message. What we need to bring to the table also is emotional intelligence. And Judy was alluding to that earlier in her remarks as well. And if you look at action, whether it's the inhibitors or the motivators, as you can see on, I hope everyone can see on the screen, you'll see along the left-hand side, all those action inhibitors, inertia, apathy, fear, isolation, self-doubt. We need to be aware of those. If your goal is to move a mountain, if you climb a mountain, the advocacy goals are sometimes quite daunting, especially if you look towards the long term. But you need to take into account the emotional impediments that could really trip you up on the way. And what are some of the solutions? What are the antidotes? Or as they say on the right-hand side of the column there, the action motivators. What overcomes inertia? Urgency. What overcomes apathy? Anger. Although you could also look at the next one down, which is hope, which I think can also help overcome apathy. What overcomes fear? Hope. What overcomes isolation? Solidarity. And that kind of relates very directly to what Judy was saying earlier, because one message I really want you to take away from this presentation is one thing: find your allies. Find your allies. That's really critical, because if you're taking on a really challenging goal, let's say you want a chief nursing officer right at that table with the Minister of Health. Let's say you want salary increases for nurses. Let's say you want a countrywide gender discrimination policy, countrywide sexual harassment policies. But let's say you have something smaller scale. In your hospital, you want to see the needs of nurses better represented at the leadership level. You're going to need all of these action motivators on the right-hand side to really to see you through, including solidarity. And that's where I say again, find your allies. Don't go it alone. Find those around you who you can draw on for strength. Is it another nurse? Certainly. But maybe someone in an allied profession, maybe someone in maybe a patient organization, maybe a particularly activist-minded patient. And we know that there are many who come through the health system and take on a sense of activism. The people living with HIV are well known for that. So that's one example. So I think you need to keep all of these in mind as we look at this. So another slide that I just wanted to show you here. Let's see if I can pull this up. Right, if you look at this chart, sorry, there's a lot of text on here, but back in the early 1970s, there's a feminist leader in the United States named Heather Booth, who came up with a really important chart that lays out step by step a couple of really critical considerations for as you're planning what your strategy is going to be in your advocacy. So first of all, obviously, is the goal. Just as Judy was saying, what's your long-term objective that you want to see? You want to see salary increases. You want to see respect and dignity on the job. What are the specific steps measures that you want to see to achieve that? Let's say it's the chief nursing officer, as we were hearing earlier. Okay, if that's the main goal, are there some intermediate steps that would be steps along the way that will give you a sense of momentum in achieving that longer term goal? So those are some important considerations. What kinds of goals will give your community a sense of their own power? Why is that important? Because you're going to need that to take on even bigger challenges. Skipping over a couple of columns, what are the targets? So the question there is, who has the power to give you what you want, right? Who has the power that you need? Who do you need to convince, right, to actually give you make the policy change happen? So there you see in that column a couple of key questions. Who has the power, and what power do you have over them? Or another way to put that is, what influence do you have over them? How can you exert influence over them? And the word you see number 2, secondary targets. Who has the power over the person that you need to convince? Is there an ally or what they call a secondary target that you can approach? So just to take an example, let's say your primary target is the Minister of Health. What's a secondary target? Maybe the secondary target is the Minister of Health's wife, who happens to be a nurse, who can talk to the Minister of Health. Maybe the secondary target is a parliamentarian, member of parliament in your country, who happens to be close to the Minister of Health, who can help persuade him. Maybe there are other allies. Maybe there's a regional leader, maybe at your county level, or regional, provincial level, who can be persuasive. But there, I think, really don't forget the parliamentarians, because you can be sure that activists in the area of health have really gone to parliaments and gotten results. And I can point to a couple of examples in the area of tuberculosis, for instance, a field I was working in for many years, where really going to the parliamentarians and finding allies, recruiting them and building them up to be champions, rewarding them along the way as they climb the championship scale. I'll put a link to that scale, by the way, in the chat function. Is a way to build someone who can really be your champion, can take an issue to the Minister of Health, or can author new legislation to resolve the issue that you're concerned about. So if we look back a few ways in this chart, organizational considerations, what are some of the specific ways there? I think you need to look at your strengths and your weaknesses. When it comes to constituents, allies, and opponents, what there is, who are you fighting for? Who's going to benefit from the change? Who are your potential allies? Again, I said, find your allies. And then who are your opponents? We have to be honest about that. For some things, there's going to be some people who will be resistant. How strong are they? How are they organized? What are ways to go around that obstacle? And then if you look at the tactics one in the far right that's a really rich list of possible tactics. And I think that as you look at that includes everything from street protests, strikes, okay, to media events, public hearings, accountability sessions, elections, lawsuits, a whole range of options there. And there, I think with tactics, you really need to look at the calendar. So what are the opportunities that you see coming down the pike, that you see in the road ahead, whether it's the consideration of an important budget measure, whether it's an appearance by a key elected official, a parliamentarian, at the local level that you can go and attend to and raise your hand and say, wait, what about the needs of the nurses, where you'll be able to personally have an encounter or a conversation with your decision maker in this case. So the tactics, I think, are really important, but it's governed by those opportunities as you look at the calendar ahead. Map that out ahead of time as you start in your advocacy campaign, keeping in mind what I started out with at the beginning of those, the emotional side of this, that you need to pace yourself, because this is, in many cases, this is a long haul. You need intermediate victories to keep you going, to give you a sense of forward progress, and to give your fellow nurses, your comrades in the struggle, a sense of forward progress as you make your way towards the big goal. So those are a couple of considerations I wanted to share from that point of view. So as you look at some of the immediate opportunities, I think, as Judy quite rightly mentioned, domestic financing. If you look at the responsibilities of governments, we need to take these issues right to the ministers, right to the parliamentarians, and not just think of them as institutions. It's not the Ministry of Health that's your target, it's the minister, right? It's the people. We need to think of what motivates them and what will persuade them to actually adopt the change that we need. So as you look at some of the key opportunities, obviously domestic financing is going to be critical. You need to know and understand the domestic budget. But in addition, I would say look at some of the international opportunities from donors. If you look at PEPFAR, and take an example, PEPFAR has an annual process called the Country Operation Plan. So I'm just going to pull up that slide over here. There's a terrific organization called HealthGap that has a guide. It's called the Rough Guide to Influencing the Country Operation Plans. And they have a very handy calendar that shows you step by step what some of the calendar items in terms of what goes into that country operation plan. And by the way, human resources for health is a really critical component there. If you look at the guidance that all the PEPFAR countries receive, human resources for health is a key component. So you need to look at that, and then look at this calendar and look for your opportunities. And again, find your allies. Who can you take these issues to when it comes to nurses who will be attending some of these COP planning events, some of these PEPFAR country dialogues? Look to groups like International Women Living with HIV/AIDS, ICW. There's a potential organization. There are other groups too, and we can talk about that in the Q&A. Another opportunity is with Global Fund. And I want to make sure that you have that one on your radar, and particularly look at this organization, Women for Global Fund. That's easy to find on the internet, women4gf.org. They have a beginner's guide. As you notice, it gives you all the information you need in terms of how to influence the proposal that goes to the Global Fund. Remember, there's a lot of flexibility about what can go in to the Global Fund proposals. You need to be at the table, though, to influence what those proposals are and find your allies. If you're not at the table, who can take your issue to that table? So that's an important consideration. There's the COVID-19 response mechanism is being given a really large amount of money by the US government very soon, in April, $3.5 billion. And human resources for health is one potential use of some of that money, but you need to be at that table to influence it. Don't forget this website and check that out, because I think that's a good opportunity. Another opportunity I would mention, and I'm going to stop here and then we'll go to Q&A, because there's lots of questions I'm sure you have, which is the individual missions. If you look at the USAID mission, if you look at the mission, if you look at the JICA, the Japanese International Cooperation Program, those are meetings that could help you identify some additional sources of funding, whether it's training, as Rachel was saying, or or other sources of grants. And so I think those are important meetings to have. Go and meet with officials and talk about the issues that are concerning you. With the United States, with USAID mission, we have a new administration, as you know. There's a really strong interest in supporting health system strengthening. Make your case in a really compelling way, in a simple way, with a specific request, and start forming those relationships with potential funders. So I'm going to wrap it up there, and thanks so much for your time, and we'll have some Q&A, I'm sure, and go back over these issues.
David, thank you so much. We've had a number of requests for your slides, your Word file. So any links you could post, or even if you let us have them, we'll share them afterwards. Or we could put them on our advocacy toolkit site. And don't forget to go to that on the Nursing Now website. We do have a toolkit that you might find helpful, which does go over some of what David was talking about, but David's slide definitely enriches that. Thank you so much, David. We've had a number of questions. Sana Gul, who has worked with us before, has made a comment really about CNOs, saying that it's no good just appointing a CNO. You have to have a CNO who has resources, and this links with what you were saying, David, has to be at the right decision-making arenas to have any influence. So this is an issue that we are often faced with, actually not only in nursing, but in professions where women are predominant. I think it's a kind of a trick sometimes. You promote somebody and you don't give them staff or money, and so you're kind of trying to succeed against the tide, and certainly that's the case for many nurses. You know, you get a good position, but you don't get the authority and you don't get the resources to make that effective. So do any of our panelists have any hints for nurses? How can you become more influential in the roles in which you find yourself? Rachel, you're a very influential person. Have you got any hints that you could share with us?
Let me get myself off of mute. I thank you for your kind words, Barbara. I mean, I think one point that I didn't raise entirely in my presentation, but is a little bit in the nitty-gritty, but important, is simply knowing who your health workers are in a country. Health workers count, nurses count. Oftentimes, whether it's preparing for who will deliver a vaccine or who should receive the COVID vaccine, Ministry of Health or even the Nursing Council may be very challenged to just know where their nurses are and what qualifications they have at what levels and so forth. And so, being able to bring some hard evidence that may be within a national human resource information system, that might be, getting literally some numbers on who are your nurses and where they are. Connecting information on personnel to service delivery to demonstrate truly the contribution, the very important contribution that nurses do make, could be the sort of argument that could then elevate the role of a chief nursing officer. To the extent that, evidence will get you a certain way. I think David raised the point that emotional messages and personalized messages are going to be a really potent combination. That's where I'd start with, but don't have all the answers. Would love to hear from others too.
Thank you, Rachel. Those are very good points. You have to bring something, don't you? You have to say, I want you to invite me because this is what I'm bringing. And that's very important. Ben, I just want to link that to a question that actually you were talking about in the Q&A box, which was about engaging nurses to participate. I wondered if you'd just like to sort of say what you actually wrote there for everybody.
Oh, well, I by the way, just to say that I'm surrounded by women who are nurses who I admire. Barbara is one of them. Judith Ellis, my boss, is another. Marilyn Lynch, who works for THET, is another. All of these are people who have dragged themselves through academia, who have forced themselves into the presence of others, who have identified those kind of bottlenecks which are holding nursing back and pioneered solutions. And by the way, one of the reports I often read is the one that you did with IntraHealth. I just love that report that focused on surveying nurses and identifying some of the stigma and some of the problems in terms of the attitudes towards nursing as a profession. So I think everyone has a contribution to make in that context, and that's very exciting. So when I was talking about the collaboration with Burdett and the future of the Nursing Now Challenge, what I'm saying is that we're interested in the individuals who have stories to tell, projects to deliver, publications to write that will help advance nursing and lift the status of them as individuals in the process. What I said more generally about health partnerships was there is no question that within this kind of glamour of global exchange and sort of exchanging information across borders, which is thankfully so much easier now thanks to webinars like this, but there is, the doctors tend to have an easier time of it, particularly from the institutions they work for, who are always a little bit paranoid that they might lose the doctors. And they seem to take for granted the presence of nurses in the way that they don't with the doctors. And I'm sure there's a gender dimension to that, as you've said, Barbara. But within THET's life and the health partnerships, we're forced to spend more time with nurses and midwives, whether we like it or not, because they're just so important to delivering healthcare, as Rachel said right at the beginning.
Yay, we feel your pain, Ben. They're essential. Judy, I know that you are a key influencer. And, we know, I mean, we're both nurses and we know, and we both have, worked hard to try and influence others, I think, in various worlds. What do you think? You talked a bit about leadership programs. I am increasingly interested in the idea of competency-based leadership, especially for nurses, because that really shows where you're going. Have you any experience of that?
Thank you. Sorry, mute. Thank you, Barbara. And it's interesting that you say competency-based, because for me, that's one way to influence. One of the things, and Ben, you're alluding to this when you say doctors take us for granted. And the reason they do that, at least here in Africa, is because nurses don't demonstrate the competence. So after some time, people don't see what you bring to the table. And yet, I say that that's a mistake on our part. So in answer, I would like to say that the onus is on us as nurses first to sharpen ourselves to the best level possible, to the sharpest that we can. Because in my journey, people listened to me because I demonstrated the competence. People listened to me because I showed the expertise. If I'm at the bedside and I'm with the patient, I need to show what it is that I'm adding. I'm not just another piece of furniture. And often this is the thing that we see in Africa. We do the ward round and the nurses are at the back. They don't want to hear what's being said. They don't want to understand the discussions. They don't want to ask questions. Now let's say that, in fact, for doctors, one of the best things to get doctors to be on our side is ask them questions. When I sit and ask the doctor, why did that happen? Why did the patient have a fit? Why did this convulsion happen? What was the reason? The doctor looks at me and says, wow. And immediately that thing that is in all of us human beings just rises to the fore. And so the challenge I find, I'm again always talking about Africa, is that we don't demonstrate the competence. So after some time, people, their eyes glaze over when they see the nurses. It's just like, oh, these people, they are just there. So that's number one. We need to sharpen ourselves and continuously do this, because especially in our field, things change literally at the speed of light. So what was being done in terms of, let's say, treatment last week is not the same that's being done today. And if you don't know, then how are you going to show that you're competent if you're giving a drug that's now obsolete, or that the dosage has changed, or that the administration of this drug has now been overtaken and is being done in a different way? Then number two, I think as women, let us use the power of being women. That's another good thing we can do as nurses. 9 out of 10 of us are women. What is the thing that we can do as this thing called female to help us? And so for me, it is straightforward, because everybody is interested in the thing that makes me a woman. Why don't I use it? I'm compassionate. I'm a caregiver. I mean, there's certain parameters around being a woman that I turn them around and say, no, the fact that I am a caregiver doesn't make me less, it makes me more. Because people say, oh, you should be there mopping people's foreheads and you should not be at a masculine decision-making table. Then I say, no, I'm at the decision-making table and bringing compassion to this table, where the men are not even remembering that people are human beings, or whatever the case may be. So just a few things that to me have worked.
So, yes, Judy, you make a very important point. We need to be proud that we're women and what we bring, you know, because of our upbringing, because of our sensitivities and so on. Not that men don't bring those things too, emotional intelligence and so on, but we need to be proud of it, and proud of the men who bring it and the men who are our allies in this. So, yeah, good, very good. And somebody else has commented that, you know, nurses in leadership positions who are disempowered are not always able to adequately empower others as role models. And I do think that's another important issue, and certainly one that we found in the study that you mentioned, Ben, that we did, that nurses often did report they didn't feel confident in speaking out, in speaking their minds, and they didn't feel empowered. So for all of us, all of you who are listening, who are in senior positions, this is something we need to remember. We need to be empowering somebody else. And I've said it before and I'll say it again, every leader needs to create another leader. That's part of our responsibility as a leader. So, you know, that's more important, I think, for nurses than anybody, because nurses have a bad reputation for what we used to call in nursing eating our young, which I think it translates to not being very supportive to younger early career nurses. So we need to address that, you know, as Judy said in her presentation, there are things within nursing we need to address as well. Okay, so let's move. There was a very interesting question posted early on by Sherian Bagwan, which, if I interpret it correctly, is something that I have thought about. I think what Sherian was wondering was about migration. And, you know, nursing is a global profession. It's globally accessed. So we recruit nurses in the UK from all kinds of places, from everywhere. And we know there's a sort of migration carousel around the world for nurses. How would the world look? David, I'm going to ask you this as a world observer. How would the world look if nursing was acknowledged to be a global profession and it was kind of a free-for-all? Could everybody everywhere could access nurses from everywhere? What sort of things would we have to be thinking about and be aware of?
Yeah, I mean, it seems to me that if you, you know, on the one hand, you have, severe shortages in many countries and working conditions that lead nurses to want to emigrate and find better opportunities in the UK, in the Middle East, in the United States, and I think that's their right to do so. But at the same time, we have to dig a little deeper and understand the economic drivers of that, the incentives, and the ability of these countries to offer the incentives to attract workers to leave, and understand, what the economic inequalities that make that possible. So it's if global migration were simply as easy as flipping a switch, it would be interesting to see what result there would be. But there's certainly a need to address both sides of it. The conditions that lead nurses to want to leave home, emigrate, but also the drivers. And in the United States, we simply don't invest enough in nursing education. So we should have a shortage. Well, we need to look in the mirror and ask ourselves why. Why do we have that? And and we have difficult working conditions for nurses here, but we need to ask the question why, and what can we do about it, and clean up our own house, I think, is as Judy was mentioning earlier.
That's absolutely, it is actually about production, isn't it? Producing the number you need. Rachel, then I'll bring you in, Ben. Rachel, any comments on that? You're a global workforce person.
Absolutely. It's a really important question, and is often thorny beyond the realm of many ministers of health, beyond their influence and knowledge in a lot of instances. I mean, I think back to, I was a Peace Corps volunteer in Cameroon, and I would visit the local hospital. It was in the northern part of the country. Muslim influence, there's a certain cultural approach, and many of the nurses, because of the ability of nurses from the South who were Christian to be trained, had got pushed up to this other part of the country where they'd never been. They didn't know the local language, and the quality of care was pretty negatively impacted. And you might see that same nurse trying to push. She wants to be with her family. She wants to, have a job where she can be connected to her community and will be very motivated to do her best. And was up against challenges. You'll often see many of those nurses who are at the highest level in low and middle income countries migrate to then work as entry-level nurses or home health aides in other much more heavily resourced contexts. So it's not often lateral moves, and those who are hurting the most from that sort of migration have little to do. And I think that also speaks to the points that Judy and I had raised about education, about if we can invest in nursing education that is community-based, where we have faculty and are able to recruit and really support nursing students from those communities. Certainly anyone should be able to seek opportunities as they go, but there should be more opportunities where population health needs are the greatest. And so transforming education to really adapt to that. And I think just a final point is to your comment about cultivating new leaders. Nurses are at the hub of primary health care and have many of them really the most strong interpersonal skills for patient-centered care. They're the connectors. And so when we look at community health worker programs proliferating in many low and middle income countries, how can nurses are often the supervisor. That's a workload, burden that's pushed to them, but how can that be an opportunity? And how can nurses also say, let me pull together the allied health professions. Let me pull together, I'm the one delivering on primary healthcare. I'm the leader at my primary healthcare facility. How can I, develop interprofessional relationships and allyship across all of those different kinds of health workers? I think it can go far.
Thank you, Rachel. Ben, did you want to come in on this one?
Yes, just very briefly. Thank you, Barbara. THET produced a policy paper, which I've shared a link to, which is called From Competition to Collaboration. So whilst we agree, David, with the main theme, which is we need more nurses, we need more health workers, full stop, what we were doing was focusing on the issue of migration. And just a couple of facts. Do you know that migration to OECD countries has increased by 60% in recent years? So migration is a fact. Do you know that 16% of nurses working in the NHS and 36% of doctors working in the NHS were born overseas? So there's something about the fact of migration. We can look at the push factors, we can look at the pull factors, but migration is here to stay. So the question we were asking ourselves is, how can we shape migration in a way that brings benefit both to the sending country and the receiving country? And that had something to do with looking at the NHS, the UK National Health Service, through the lens of not just being the largest healthcare service in the world, 1.3 million people are employed by it, but also the largest potential training resource in the world. And so how can we sit down with governments and really plan for earn, learn, return, for movements of people over the period of their career so that they're active at one time in the UK, but then perhaps returning to their country of origin. So we're very much in the market for those kind of win-win solutions, which recognize that migration and the right to improve yourself and the inquisitiveness of, wanting to go and work in another country, those are things that are here to stay. But it's how can we move from competition to collaboration?
Yeah, that's thank you, Ben. I was reminded when I worked at WHO, I was the focal point for migration of health workers for 3 or 4 years back in the 90s or early 2000s, actually. And one of the things that I was asked to do was to look at migration from different perspectives. So to look at it from the perspective of the Ministry of Health in the country from where the migrant workers were leaving, to look at it from the perspective of the Ministry of Health in the receiving country, then to do the same for the Ministry of Finance in both places. And of course, in the country that's losing the health workers, they get remittances back very often. And in some countries, those remittances are more than foreign aid. So, it's not, as you say, you've got to look at the win-wins of these things. And then the most interesting part, I think, was when we began to talk to migrant workers, migrant doctors and nurses themselves. And of course, what we found was they could send money home to their families. And that money, as Judy was saying, it made all the difference because it helped them get an education very often. And, one nurse that we actually brought to the World Health Assembly to talk to ministers, she was telling us that she had bought her son a computer, and on that computer, he was able to do his exams and get into university. And she said, had she not been working in England as a nurse, she would not have been able to do that. So what it did was it made us walk in somebody else's shoes, which is always important, isn't it? Because I think sometimes, it's very tempting to say, well, I know the best policy for this, whereas in fact we don't. So we're drawing to a close, but Julie, I want to offer you the last word, partly because we've had some comments about faculty and faculty shortages. And I think that would be something very interesting to comment on. You're at the sharp end. To produce more nurses, you've got to have a department of nursing and you've got to have faculty to teach. Where do you see this going? What's your closing words to us?
Thanks, Barbara. I think it's true that there's a huge shortage of faculty. And so it's important that we look at innovative ways of how to go around this. One of the things that, for example, we have done through, I think it's Rachel who alluded to the NEPI partnership. I ran NEPI for about 2 years. It ended in 2018, which was US funds to grow nursing education at mainly pre-service level. We worked with 22 schools of nursing in 6 countries in Africa. And one of the things we did, for example, was make sure that nurses in the clinical area were teaching, because often that's a complete, the teachers teach and they don't go to the clinical areas, and the clinical people don't even know what's being taught. And there's always been a tension there. So one of the things we did, for example, in Ethiopia was make sure that the clinicians at the bedside came in to teach, and they had to give 1 hour of their week to do that. And then we worked with the Ministry of Health, who was paying, the hospitals where they were working, to tag on some added remuneration around this, so that became something sustainable. And I must say it worked very well. This is again looking at shortage around faculty. The other thing that I am working on doing is having any of the programs that anybody offers, short, especially the short continuous professional development, the CPD courses that are offered, linked to academia. So for example, to my university, to where I am placed, to give academic qualification. So if you do a short course in leadership and nursing, for example, a 6-month course or a 9-month course or whatever it is, that can then, I will work with you, will offer a certain amount of, added work at the university, of course, mostly remotely, to then give you a qualification, which is a huge incentive, does not make nurses run off to the US and do all sorts of things. So that's one thing I'm working on. Another thing I'm working on is to offer the doctorate of nursing practice, which is mainly offered only in the United States, done in Africa. Again, hitting many birds with one stone: retention, migration, and all the things you guys are saying correctly, to then give the added qualifications that are so critical. The other thing, of course, is to then work, because there's no point of having this doctorally prepared or master's prepared or bachelor's prepared nurse, and then she can't be employed. So working in tandem with the ministries of health in Africa, where again, and now I keep coming back to leadership, we need really this chief nurse. So I'm very happy with what Badet and Thet and all you guys are doing to help us in Africa get there. Because now when I have these chief nurses everywhere, our voice will not now go unheard. And then with that, we can now push for people to be paid. When these people are paid at their level, they are not going to run to the US and run all over to London and Edinburgh and all over the place. Okay, they will, but not in those huge numbers. And then you now begin to build that critical mass. Number two, keep the mentorship for the young people. What is happening, and I'm seeing this in the US, unfortunately for you guys in the North, your nurses are dying and they're not being replaced. You're going to get to a point you will have none. So we have to start thinking critically how to make this pipeline continue. Otherwise, we're in big, big trouble. Okay. So like Rachel said correctly, the nurse who is 65, don't put her to pasture. She's so valuable. Bring her back as a teacher, mentor, coach, because those are some of the things I'm doing. Is now in the programs that I'm offering, I need coaches and mentors. So I'm reaching out to my friends in the global North to help me. All these things are done online. So there's not a big, huge deal around that. If Ben gives me money and David gives me money, I will pay some small stipends to all these, my coaches, mentors, faculty in the global North, to teach people here in Africa. Win-win. Thank you.
Judy, that's a great note to end on. Thank you so very much. And thank you to all our panelists. It's been a wonderful session, and absolutely, it's right at the heart of our season of advocacy, quite rightly. You've given everybody a lot to think about, and the comments in the chat reflect that people have really appreciated it. So thank you so much. Don't forget the Thet conference on Friday, and keep looking for the Nursing Now webinars. We've got another few. We've got a masterclass in advocacy, another few things coming up. So keep looking at our website, go to the Thet conference, and we wish you good health. Thank you so much.
Thank you.
Thank you, Barbara. Thank you, everyone.
Thank you, everybody. Bye.
Thanks, all. Keep up the good work.
Bye.
Bye, Judy. Thanks.